Welcome to ANA Investigates, a monthly podcast covering the latest in neurology and neuroscience brought to you by the American Neurological Association. I'm your host, Adeline Goss. Today on ANA Investigates, we'll delve into the medically and legally complex topic of cannabis. The legal landscape around marijuana has changed dramatically in the U.S. in the past 15 years. Many of our patients now have legal access to products derived from cannabis, and they're turning to us for advice on whether these products can treat their neurological conditions. Products derived from cannabis have been studied in a range of neurologic diseases, and one product has shown modest efficacy in patients with Dravet syndrome and Lennox-Gastaut syndrome and is approved for the treatment of these conditions. But the data for using cannabis-derived products in certain other neurologic conditions is less convincing, and the use of these products remains controversial. How should we counsel our patients about this? Today we'll orient you to the medical use of cannabis and cannabinoids, with an emphasis on their use in treating the symptoms of multiple sclerosis. I'm joined by Michelle Cameron, Associate Professor at Oregon Health and Science University in Portland, Oregon. Dr. Cameron is both a neurologist specializing in MS and a physical therapist, and she teaches and consults on medical uses of cannabis and cannabinoids. She offers as a disclosure that she consults for Greenwich Biosciences, which manufactures 2 products derived from cannabis. So, Dr. Cameron, a lot of our listeners may not be familiar with how cannabis and cannabinoids act on the nervous system or how these substances are regulated in the United States. I'd like to spend our first few minutes going over some of this background. Let's start with a simple question. What is cannabis, and how does cannabis differ from cannabinoids?
Sure. So cannabis is a plant, Cannabis sativa generally. It's a plant that's been grown for centuries, and it contains a wide range of chemicals. The bioactive chemicals are called cannabinoids, and the 2 most researched and the most prevalent cannabinoids, so bioactive chemicals in cannabis, are THC, tetrahydrocannabinol, and CBD, cannabidiol.
And what are the differences between THC and CBD?
So THC is psychoactive and intoxicating, so that's what most people use, quote, for fun. And CBD is, although maybe slightly psychoactive, is not intoxicating.
Okay, great. And what do we know about cannabinoid receptors and their distribution throughout the nervous system?
So we know about 2 specific cannabinoid receptors, eloquently named CB1 and CB2. CB1 is largely distributed in the nervous system centrally, primarily, and somewhat peripherally. CB2 receptors are largely distributed actually in the immune system and not in the neurologic system.
And so when we're talking about cannabinoids, are we primarily talking about their effect on CB1?
So we think so. When we talk about cannabinoids in cannabis, THC and CBD, we know that THC binds to CB1 and probably also to CB2. Interestingly, CBD doesn't bind to either of those cannabinoid receptors, so it may modulate binding of THC, or it may be acting at other more ubiquitous receptors like TRPV1 receptors and things like that. And then I think another piece to sort of bring up in this conversation is what are called endocannabinoids. So these are, like we have endogenous opioids, we also have endogenous cannabinoids in our body. That's likely why we have cannabinoid receptors. They weren't made as receptors for chemicals in plants. They were, quote, made as receptors for chemicals in our bodies.
When we're talking about the medical use of cannabinoids in the nervous system, that use is inextricably linked to the legal status of cannabis in the United States. And I wonder if you might tell us a little bit about the legal status of cannabis in the United States.
Sure. So in the big picture story is, by federal law, cannabis is Schedule 1. That means it has no medical use or potential for benefit and potential for harm or abuse. So that's the sort of the big picture. As we get down into the smaller and smaller picture, we have state laws that aren't always consistent with that federal law. So as probably many of our listeners will know, in many states, over 30 states in the United States today, there is some medical legalization of cannabis. So cannabis can be obtained for medical use only. And then there's around a dozen states, I believe 10 to date, that have also legalized recreational use of cannabis.
So in the United States, what is required to research the medical use of cannabis and cannabinoids?
It's super complicated and changing, but big picture, what you need is DEA approval to use a Schedule I drug if you're using a non-FDA approved cannabinoid, and then you need FDA approval and an IND.
And an IND is the investigational new drug application from the FDA, correct?
Right. And then you're going to need special storage, and you're going to have to obtain that cannabis. You can't just go to your local dispensary and buy cannabis and do research on it. You have to get the cannabis the DEA grows, which they grow in Mississippi in one place. And it's one strain, I believe, at this time. And so you have to use their cannabis and get their blessing, multiple blessings to do so.
So for many years in the U.S., we've had FDA-approved synthetic cannabinoids, dronabinol and nabilone. And then last year, a drug called Epidiolex was approved by the FDA, in spite of the fact that its active ingredient, CBD, is a Schedule I substance. Do you mind explaining how the legal status of these drugs differs from that of CBD or THC?
Sure. So I'll take them one at a time. Dronabinol, and many people may know it as Marinol syndrome, is a synthetic THC, and it's FDA approved to treat loss of appetite that causes weight loss in people with AIDS, and also for severe nausea and vomiting caused by cancer chemotherapy. Nabilone, again a synthetic, again FDA approved, not made from plant, and is FDA approved for, again, severe nausea and vomiting caused by cancer chemotherapy. In contrast, Epidiolex, which is a form of it's CBD made from plant, has been recently FDA approved for treating seizures associated with the Dravet and Lennox-Gastaut. And the reason it sort of had to go through extra hoops is this was the first cannabis plant-based medication that was approved by the FDA in the United States.
Can you give us a general sense of the additional medical cannabinoids available in other parts of the world?
Really the only other cannabinoid we see is this product called nabiximols, which is an oromucosal spray that contains a 1-to-1 ratio of THC and CBD, and is purified down again from cannabis plant. They're not quite as much as Epidiolex, so it does have other products in it. It's more of a whole plant extract. And that's approved in various parts of the world, but not FDA approved.
And how does this differ from what's available to physicians off-label and what's available for research?
When we speak about off-label, I think we have sort of two conceptions of that. There's, could you prescribe these medications in an off-label way? And you're always, as a physician, allowed to prescribe off-label. So any of these are, quote, available off-label, although it may be very difficult to get any insurance to cover them. The other kind of off-label is what people get if they're in a state where there's approved medical marijuana. And that is completely different. Now we're dealing with plant-based and many, many products. And physicians don't prescribe these in general, although the law in states do vary. And in general, physicians are signing forms that people have qualifying conditions for marijuana, and then the person just goes and gets it. But the physician isn't writing a prescription with a dose or a type or anything else.
Thank you so much for giving us a sense of the landscape of cannabinoids in the United States and around the world. And now I'd just like to focus on your area of neurological expertise, multiple sclerosis. Patients with MS suffer from a variety of symptoms, including not only weakness, but also numbness and bowel and bladder symptoms, cognitive changes, as well as pain, spasticity, muscle spasms, headaches, fatigue, and depression. And while there's still only limited research on cannabinoids to treat these symptoms, the strongest research is around the use of cannabinoids to treat spasticity and pain. So if it's okay, I'd like to start with spasticity. Tell us about the research on cannabinoids for spasticity in MS.
So there's been a number of trials now of cannabinoids for spasticity in MS. Most of these have used nabiximols, the one-to-one THC to CBD combination. There's one with THC alone, and then there's a couple with this Cannadol product that's never been commercialized. It's a 2-to-1 THC to CBD combination. And big picture, they generally have found a positive response on patient-rated spasticity, and that's generally rated on a numeric rating scale, so a 0 to 10 scale. The patients show a reduction in spasticity with nabiximols compared to placebo.
And did any of these trials actually look at objective measures of spasticity?
So a number of the trials have used what we can best call objective measures of spasticity, which is the modified Ashworth scale. And in general, they've not found that scale to move significantly.
What do you make of that difference between a significant response in patient-reported spasticity versus a significant response in what we have as an objective measure of spasticity?
It's a tough one. I don't think I completely know. I think that there's a lot of possibilities. First of all, when we think of patient-rated spasticity, probably most of the listeners here today are neurologists, and you have a pretty good sense of what you mean by spasticity. But I doubt many of your patients come in the door and say, I have spasticity spontaneously. And if you ask them how bad their spasticity is without being very clear about what you mean by it, they may be describing a lot of things, from pain, discomfort, tightness, something that doesn't feel good, probably in their muscles. So when patients say their spasticity is better, they may be reporting pain, quality of life, discomfort, or what we would call spasticity. So what exactly they're reporting on isn't clear. The other issue is with the clinician-rated or objective measure. The modified Ashworth is a 0 to 4 scale with a 1+, so you get one extra option. But it really has very little sensitivity in it. And so we may be failing to detect changes just because we have such a crude clinician scale. Or it may just be that patients know their bodies better than we do.
I'd like to also talk about MS-related pain, which has many manifestations, including headache, back pain, neuropathic pain in the limbs, trigeminal neuralgia, and painful spasms. What has the research shown about the effect of cannabinoids on chronic pain in MS?
Although the research has generally been positive, the quality and quantity of that data is not as impressive as that with spasticity. And so, although we're optimistic, I would say, that there's probably a benefit, I really think it's an area that needs further research to fully understand and to scale up, to know if there's a benefit. And as you say, there's so many varieties of pain in MS. What exactly are we treating? And often the question is somewhat vague in the studies that have been done. And it's rarely been a primary outcome of those studies. It's often a secondary outcome in studies that are primarily focused on spasticity.
In addition to what you've mentioned, what are some of the major limitations on the research in cannabinoids in MS-related symptoms?
I think probably the biggest limitation is in interpretation or in translation. Many providers and patients actually don't want to answer quite that question. They're not really wanting to answer the question of, do cannabinoids work for my symptoms, but does cannabis work for my symptoms? And that goes back to where we began. Cannabis is a very complex plant. It does have THC and CBD in it generally, but the quantities can vary in all sorts of proportions, and there are many other cannabinoids in these plants. So if somebody goes to a dispensary and they have, I say it's like going to the wine store. Which wine do you want? They're going to have a similar selection of cannabis and cannabis products there, and the research doesn't and probably will never answer for you which of these might be the best for your patient. And another limitation is that most of the research we do have that is probably reproducible is with nabiximols, that 1-to-1 THC CBD spray, and that isn't available in the US. So if you want evidence-based practice and you want to use what we do have data from, we don't have that product here.
What do we know about the safety and the adverse effects of cannabinoids?
So if we look at the studies of cannabinoids that have been done in randomized controlled trials, what we see are, I think, expected effects. Things like headache, confusion, dizziness, sedation. In general, what I think you might expect of feeling stoned, and probably dose dependent. What we start to see, however, when we look at people who chronically use cannabis is quite a different range of issues. So there's a distinct suggestion there may be cognitive adverse effects, particularly in multiple sclerosis. And this comes from a few now, but very small studies that have seen that people who are chronic cannabis users with multiple sclerosis have poorer performance on cognitive tests and are more likely to be cognitively impaired. Although excitingly, a study I saw came out just recently in 40 people who had MS, were chronic cannabis users. When they stopped using and withdrew, their cognition did improve. So this does seem to be, at least to some degree, reversible. And then when we take a look more generally at people using cannabis, there's an increased risk of psychosis, and particularly in those who have an increased prior risk. There are studies that suggest an increased risk of suicide, potentially both in those with psychosis and without. There's potentially acute, so within the hour of using, risk of cardiovascular adverse events, myocardial infarction. And then we have cannabis use disorder, which, like other substance use disorders, is continued use in the face of adverse effects, where people develop tolerance and have difficulty stopping using despite adverse effects on the rest of their lives.
So many patients with MS are already using cannabis for their MS-related symptoms. How do you talk to patients who are using cannabis without a doctor's prescription?
So the first thing I do, if I wonder if patients are using cannabis, and I do tend to ask all my patients if they're using cannabis so I don't have to try and guess, is that it's best if I know what they're using in general, whether they're using supplements, using cannabis, using alcohol, so that I can adjust my therapeutics and my expectations with that knowledge. If they ask me, what do I think about them using cannabis, I'll generally share with them what I've shared with this audience, the most likely risks and benefits, with the risks, given I treat patients with MS, largely for most of them being cognitive, and the benefits probably largely being spasticity and pain reduction. And then we do discuss the legal issues to the extent that they're relevant, and that they should be aware that here I'm in Portland, Oregon, where we have, quote, legal, medical, and recreational cannabis, but it is still federally illegal, and their employer may not find it acceptable that they use, and so they should consider that.
Great. Thank you so much for sharing your approach to these conversations with patients. So for our listeners, we've covered a lot here today. Let me take a moment to summarize what we've learned. At the federal level, cannabis is classified as a Schedule I substance, but patients in many states are now able to legally purchase cannabis-derived products for medical use. To date, 3 products related to cannabis are FDA approved, 2 synthetic forms of THC, as well as 1 plant-derived CBD oil approved for the treatment of Lennox-Gastaut and Dravet syndromes. In multiple sclerosis, data shows that various cannabinoids may be effective in reducing patient-reported symptoms of spasticity and MS-related pain. And while cannabinoids are generally well tolerated, they've been associated with a range of side effects, including worsening cognitive issues in patients with MS. Lots to think about here, Dr. Cameron. Thank you for taking the time to walk us through this.
You're welcome. Thank you.
Dr. Michelle Cameron is both a neurologist and a physical therapist and is associate professor in the Department of Neurology at Oregon Health and Science University in Portland, Oregon. For ANA Investigates, I'm Adeline Goss.
This has been an episode of ANA Investigates, the official podcast of the American Neurological Association. Thanks for joining us. To learn more about today's program and to access more of the incredible content produced by the ANA, check out myana.org. Adeline Goss is our host. Our producers are Romer Gioccaden, Adeline Goss, Michael Halstead, Megan Ritchie, and Jim Sigler. Our editor is Jen Hurley. If you'd like to learn more about receiving CME credit for listening to ANA Investigates, visit myana.org and navigate to ANA Investigates under the Education tab. For more information not covered in today's program, check out the official summary of this episode, published in one of the ANA's journals, the Annals of Neurology or the Annals of Clinical and Translational Neurology. Copyright, the American Neurological Association.